Good afternoon, everyone, and good morning to anyone joining from the West Coast, as we have somebody from our Environmental Health NCC in BC. We're very pleased to welcome you to our webinar, this webinar today on leveraging evidence for policy change, reducing carbon monoxide exposure in long-term care facilities. My name is Emily Clark. I'm an information specialist at the National Collaborating Center for Methods and Tools. A few points of housekeeping before we get to the presentation. You can use chat on the bottom right-hand side of your screen to post comments and or questions during the webinar. We will have a dedicated Q&A session at the end of the presentation, but feel free to post your comments and questions throughout. Please make sure that you send your questions to all participants as opposed to privately to host, which I believe is the default, so that anybody else who may have similar questions can see what's been asked. We do recommend using a wired internet connection instead of a wireless for connectivity, and there is a 24/7 WebEx helpline available if you have any issues. For any minor issues, Rawan Farhan, who is currently posting in the chat section, is available for tech support if you have any issues with your audio or visual. After today, the PowerPoint presentation will be made available in both English and French, and the English audio recording will also be made available. These are available at the NCCMT's SlideShare account, the link to which is posted on the slide and in your chat, and the audio recording will be posted on our YouTube. The link to which, again, is posted in the chat window for you. We have one polling question today. We're interested to see just how many people are joining us today. We see a number of people joined in on the line. We had about 80 or so people registered for the session. But we're interested to see if anybody's joining in groups so that we can get a sense of what our audience looks like today. So the polling question should be available for you in the right-hand side of your screen. Please make sure that you do hit submit once you've entered your selection so that it does get recorded. Looking at the responses right now, about half of our participants are joining by themselves, and we do have a couple of groups of 1 to 3 and actually one of 6 to 10. So welcome to everybody who has joined today. For those of you who may be less familiar with the different NCCs, so NCCEH and MT are actually 2 of 6 NCCs across the country. We're located across from BC all the way across to Antigonish, Nova Scotia. NCC for Environmental Health is located in Vancouver, BC, and here in Hamilton is the NCC for Methods and Tools. Rawan has posted a link for the National Collaborating Centers if you are looking for more information on those as well. I am now excited to formally present our presenters for today. We're very pleased to have with us Daniel Fong from the National Collaborating Center for Environmental Health. He's an environmental health and knowledge translation scientist. He's worked so far on a wide range of products, including those related to food safety, personal service establishment, bed bugs, mold, antimicrobial agents, and carbon monoxide. He's worked with stakeholders from multiple disciplines to help to understand how evidence can be used to support a response to complex public health issues. I'm also very pleased to introduce Susan Snelling, the Senior Knowledge Translation Specialist with the NCC for Methods and Tools. Susan has held various roles in public health at both the local and provincial level in Ontario. And her work at the NCCMT focuses on building capacity for evidence-informed decision-making in public health organizations and practitioners. So with that, I will now hand it over to Susan and Daniel.
Great, thanks, Emily. This is Susan Snelling here, and welcome to our webinar today. I'll do a little bit of introduction and setup, and then partway through we'll turn over to Daniel Fong, and Daniel and I will kind of go back and forth a little bit between some general discussion related to evidence-informed decision-making. I'll talk a little bit about a model that we use at NCCMT. And then Daniel will talk about some aspects of the particular situation or scenario that we're talking about today with respect to carbon monoxide exposures in long-term care facilities. So the model for evidence-informed decision-making that I'll get into in a second is something that we make reference to very often at the NCCMT, and we're going to focus today on the latter stages of the model because they're perhaps the best case for describing the particular work that Daniel will present. But I will talk through all the steps of the model just so that you can have some general exposure to that model. And as our name suggests, National Collaborating Center for Methods and Tools, our focus is related to methods and tools for evidence-informed decision-making. And so as we go through the steps of evidence-informed decision-making, I will talk about some methods or tools, some resources that can help you if you are trying to bring evidence into some of the decisions that are current in your situation. So with that, and I'm just going to check in. Am I controlling the slides now? I think so. The National Collaborating Center for Methods and Tools, or NCCMT, our vision is that the effectiveness and efficiency of Canada's public health system will be guided by the production, sharing, and use of high-quality evidence. And so our role in that is to enhance evidence-informed public health practice and policy by providing leadership and expertise in supporting the uptake of what works in public health into practice. So it's really in that kind of applied context where we look to the possibilities for research evidence and other sources of evidence and information as well to really take a very applied perspective on public health and support people who work in public health to figure out what will work and then how to implement that in the settings in which they work. So that's us at NCCMT. I'll turn over to Daniel to just describe briefly the NCC for environmental health.
Sure. Thanks, Susan. This is Daniel Fong. So I'm at the National Collaborating Center for Environmental Health. And our focus here is really looking at the health risks and health effects associated with the physical environment. So this is the food we eat, the water we drink, the air we breathe, and as well as the natural and built environment we live in and how we interact with it and how that affects our health either in a positive way or a negative way, or maybe it doesn't affect our health. So these are the factors we look at in our work. And importantly, we actually try to help public health practitioners across Canada to make evidence-informed decisions. So this is to provide them scientific evidence or to share best practices that are existing or to help them contextualize existing information that may be used elsewhere so that they can use it in their work and supporting their decisions. So we're not helping them, we're not making recommendations, but we're going to provide them with the information so that they can make the informed decisions in their work. And our target audience primarily involves public health inspectors across Canada, as well as medical health officers and other environmental public health practitioners and policymakers working in this area and that have sort of the relevant topics that are involved in their work. And we highly encourage the engagement of our stakeholders to create our products so that they are most useful to them, as well as ensuring that our work is going to be effective in terms of changing their the way of sort of using evidence, as well as how they approach the use of information that's out there, because there's so much of it, and it's sort of this the dissemination of it and also the uptake of it and interpretation of it that we try to help them with. And in the next slide, I think, Susan, it's back to you.
Great. Thanks, Daniel. So we've been talking about the use of evidence and evidence-informed decision-making or evidence-informed public health. This is a definition that we use to describe actually what we're talking about when we say evidence-informed public health. So this is the process of distilling and disseminating the best available evidence from research and context and experience, and using that evidence to inform and improve public health policy and practice. So certainly Daniel was just referring to the ways that that is done at NCCEH, including the involvement of stakeholders to make sure that the evidence is presented in a way that people can make good use of it and implement it in their contexts. The other thing that I'll just draw your attention to with this definition is that we are talking always about the best available evidence, and sometimes there isn't a lot of evidence, or that evidence is just emerging, or the evidence is not of the highest quality from a scientific point of view. We're not purists in the sense of only accepting the highest possible evidence and discounting everything else. If the best available is one case example of something really new that's coming out, then that's the best available evidence, and an evidence-informed public health perspective would draw on that. If there is stronger evidence or better quality evidence, and then we would encourage the use of those sources of evidence. But it really is meant to be set in the real world where things can be changing very quickly sometimes, and in those cases we look to the best available evidence to guide decisions. It's particularly true when we start to think about the use of evidence in a policy context, and that really is the featured example that we're talking about today. Sometimes the policy environment is changing very rapidly. There are many influences on decisions, not only evidence, and so we're trying to bring evidence to bear on those policy contexts as well as other contexts. Even though they may be changing, there may be time pressures and so on for decisions to be made. So all that to say, the process of evidence-informed decision-making in public health is a very applied and active kind of process. It's not a static process and takes into account lots of contextual factors. Now, this model for evidence-informed decision-making in public health is one that we draw on a lot at the National Collaborating Center for Methods and Tools. And I'll just point out a couple of things about this model. So we have some different components of influences on decision-making. I'll start at the bottom left. So, of course, we, from an evidence-informed public health perspective, would encourage people to look to the scientific research evidence when they're making decisions. And again, we're looking for the best available, whatever that might be. But we recognize that when we're making decisions in the real world and in real-life public health, it's not only the research evidence that's going to drive those decisions. There are other things too. So community health issues. How important is a particular issue on the radar within a community? What's the local context? Are there reasons that this issue is getting attention right now? Are there reasons that it's particularly pressing to make a decision about what to do right now? So those things will come into a decision as well. Then circling around to the top right, sometimes community and political preferences and actions have an influence on our decisions. So again, particularly when we're looking to a policy context, we really have to take into account the political stance. Sometimes a change in government can mean that an environment becomes more or less accepting of a particular course of action, and those things will have an influence on our decision making. We can't pretend that they're not going to. So the political context is really important to decision making. Community features like what kinds of populations live in a particular situation, or in the case that we're looking at today, there are particular features of long-term care facilities that we would want to take into account. So those are maybe an example of the community context. And then when we're making decisions about what to do, what kind of actions to implement, and so on, we do need to take into account the public health resources that are available. And that means both human resources in terms of skill sets, capacities, and so on, as well as financial resources. There may be some interventions that have been proven effective or appear to be the most effective, but that are simply not affordable, or that there would not be capacity to sustain over the long term. And for those reasons, a decision might be made not to go with those kinds of interventions just because from a resource point of view, they're impractical. Now, tying all this together in the middle is our public health expertise. And we're not robots when we're making those kinds of decisions about what to do in a given situation. We do draw on our experience, our knowledge about what's been tried before, our insights into whether there's a suitable window of opportunity at this time, or whether it might be better to wait on something until other things have fallen into place. We need to look at the big picture. And so that public health expertise bubble in this model suggests that there is a very human process to making these decisions. And although we're drawing on research evidence and our understanding of the local context, we also need to be bringing our expertise to bear, and the decision-making process is going to have some of that knowledge brought into it in terms of what really is going to be the best decision for a particular setting or community. Another thing that's implied by this model is that the quote-unquote right decision might differ from one place to another, from one political climate to another, depending on the resources that are available and so on. So even if we're starting from the same body of research evidence that this works, this doesn't work, this might work under certain conditions, it's not only the research evidence that drives the decisions, but the right decision will also take these other factors into account. Now, I'll describe a process for evidence-informed public health, so the steps that are involved in actually getting to an evidence-informed decision. And I'm going to go very quickly through 4 of the steps, and then we'll dig into the example for today in a little more detail. Sorry. So this model is a 7-step staged model of evidence-informed public health. We tend to start talking about this model at the define stage, although it is a circle, and it does mean that sometimes the model will be picked up at a different place. So sometimes, for example, people evaluate their programs or evaluate a certain action, so starting with the evaluate stage, and realize that they have some more questions, need to make another decision, and so might start from that point of view as well. So this model really breaks down the stages that can be used to take a systematic approach to the use of evidence in making public health decisions. So I will talk about each of these steps in a little detail, and then as we talk about this scenario, we'll dig into some of the later stages as we go through. So I'll turn over to Daniel now to kind of set this up and talk a little bit about the example that we'll use as we talk through this model. So Daniel, please introduce this scenario.
Thanks. So yeah, this scenario involves an incident related to a carbon monoxide exposure at a long-term care facility in Saskatchewan, which led to 31 individuals being sent to hospital and contributed to 3 deaths. So they identified several issues after doing an investigation of the incident, and also found that the levels in which the people were exposed to were actually above Health Canada guidelines for the maximum exposure limit in indoor air, which is 10 parts per million over 24 hours. So both residents and staff were affected in this incident. So 3 issues were identified actually. So one is that staff were not trained to actually recognize the symptoms of carbon monoxide poisoning in their residents. So these are physiologically vulnerable individuals that live here, for many hours a day are indoors, so they're being exposed to the air. So their environment is very, sensitive in terms of any contaminants that are in the air or in the environment. So carbon monoxide was definitely accumulating in certain areas of the building and actually led to evacuation of the wing. So that was one of the issues. The second issue is that there's no standard operating procedure at the time of the incident to deal with these situations. So there are general hospital emergency codes that are called if sort of hazardous substances are released, but nothing specific to carbon monoxide, as it's sort of an under-recognized threat, I suppose, in long-term care facilities as we know now. Also at the time, no carbon monoxide detectors were installed, nor were they required to be installed at these facilities. And even then, later on, we found that even if there were carbon monoxide detectors installed, the levels at which that were present in the environment may not have set those detectors off, as the thresholds used for residential alarms are actually quite high, and they only protect from acute high-level exposures versus the sort of lower-level 10 to 20 to 30 parts per million exposures that we're talking about here, which are still relevant to the residents because of their physiological vulnerabilities, but not necessarily impacting the health of healthy individuals. And that's why it was sort of an interesting issue to tackle, because of the difference in the health status really impacts why the exposures are important and why potentially interventions are needed to help manage and reduce that risk and negative health outcomes in these facilities and for these individuals, but also for the staff. So the second point is that there was a need for evidence to support any approach to address this issue. And that really was actually started by Saskatoon Health Region, which was the main health authority involved, and they created a policy to actually address this issue internally. We don't necessarily know sort of the scientific evidence in the beginning, but later on we did sort of add on to that by reviewing health evidence that's available on the physiological sort of toxicokinetic models of carbon monoxide being exposed to these vulnerable populations with cardiovascular disease, for example, and how the action levels should be set. So should it be at 10 parts per million as the Health Canada guidelines? Should it be more? And what's the appropriate response at these different action levels? Would you, would you just simply investigate and ventilate the area, or do you need to evacuate a certain portion of the area or move residents around? So that's sort of later on what we looked into in terms of understanding what would be, first of all, important levels to look at, and then also what would be the appropriate or health protective response, and how to manage that in a policy. And the collaboration was, so this project is really a collaborative project and couldn't be done without any of these partners, and also other partners with Health Canada providing some financial support, and also reviewing our sort of the policy and practices, and also the evaluations that we did. And also Saskatoon Health Region and Interior Health, which really were the key stakeholders and partners in our project, which helped to solidify the lessons learned and understand really how the policies were developed and implemented logistically, as well as understanding their context And that's really how we, went through some of the steps in the health evidence model, right, that MT is proposing. And we sort of did it, and we'll touch on that in terms of how they relate in the different stages. And it's back to you, Susan.
Okay, thanks, Daniel. Thanks for setting that up. And so this, when we were talking about this webinar, it really seemed like this particular situation and how NCCEH and partners responded to this situation had some interesting features to show how evidence-informed decision-making happens in practice. And one of the things that Daniel alluded to is that although we might sometimes think about defining the question or problem as the first step, sometimes it's not, it doesn't really start there. The problem kind of shows up in your lap, and you're needing to understand the situation and pull it together quite quickly. So I'll start here talking about a couple of aspects of the model, but as I said, it doesn't always go in this order. We have to show it in some kind of order, and so I'll talk about it in the most generic way. And then as we go through, you'll hear about how some of this actually happened in practice when dealing with the situation that Daniel was describing. So from a generic point of view, as we take an evidence-informed public health perspective, you do want to really understand what the problem or situation is. We often talk about that in terms of PICO, so P for population, I for the kind of intervention that might be used or important, C for comparison, so what kind of control or comparison groups might be of interest if that's relevant to the situation, and then O for outcome. What kind of outcome are we looking for? And by defining each of those aspects or leaving those open if it's not known, we can then frame the next steps of the model. The next step following from that is the search for research evidence. And we do generally suggest that people start with looking to the research evidence to see what is known, what has already been tried, what populations do we know something about with this particular problem in mind, what interventions work, what interventions don't work, what kind of outcomes do we get. So looking to that research evidence to guide some of those decisions. And I mentioned that I would be sprinkling in some methods and tools that might be of interest in a general sense if you are looking to implement an evidence-informed decision-making approach. One of the tools that we tend to suggest for people who work in public health is this one, health evidence. Health evidence is a resource that collects systematic reviews and meta-analyses related to all aspects of public health. So systematic reviews are collections of single research studies, bringing together the findings so that we're getting a broad look across the research that's been done on a particular question. So systematic reviews are great for people who work as practitioners in public health because they're efficient. You don't need to read every single article if you can find a good systematic review. So we often suggest that people start by looking for systematic reviews. You can always go to single studies if there aren't any reviews. And a good source for that kind of review evidence is healthevidence.org. I'll just show one other screen so that you know what it looks like. It's possible to search just by typing in search terms, or we tend to suggest that people do the advanced search, and you can do that using the little circled part on the right. Advanced search will allow you to use drop-down menus to search by particular topics, by certain populations, and so on. Now, you're not going to find the answer to everything in health evidence, but health evidence is very comprehensive in terms of the kind of systematic review evidence that is out there related to many public health questions. Once we have a sense of what the research evidence might tell us about what interventions have been tried, what's effective for the question that we're trying to explore, then we want to appraise the quality of that research. As you all know, it's possible to do research that minimizes bias, that takes steps to not predetermine the outcomes, but to let the outcomes come and give a true reflection of what's happening with that intervention. So critical appraisal of the research methods used to generate the evidence that we're looking at is a really important step so that we know whether we're getting the best available as opposed to just anything that's available. We, of course, prefer high-quality evidence and methods that reduce bias so that we can feel confident that whatever those research studies are telling us about, that we can trust the conclusions. Following from that step, then, we would synthesize all of the different findings. So we may have found more than one study, more than one source, more than one systematic review. Sometimes those results conflict, and we'll need to decide what the best course of action is. So synthesizing is that step of interpreting and bringing together the information that we found. And then we move on to the adapt step, and it's here that we'll start to dig in a little bit more to the scenario that Daniel was talking about. So in the adapt step, we have found some information, and we adapt to the local community. So I'll echo back to the model for evidence-informed decision-making that I talked about just a few minutes ago, and point out that although we are interested in the research evidence and what maybe the suggested interventions are, we also are interested in those features of the community, the local context, the community preferences, the acceptability of certain interventions over others. So it's those other bubbles that really come into play when we start to adapt to local context. So I'll turn over then to Daniel to talk about the kind of process of adapting what was known to the local context to try to find a solution that would really work in this situation.
Great. So yeah, in the adapt sort of stage or phase in the model, we found that we actually did a lot of that in terms of the process that we used. Although we didn't necessarily think that way, it definitely did fit the model in terms of the adapt stage. So one of the first things we did was actually to convene a group of experts to discuss the development of what would a health protective carbon monoxide management strategy look like in long-term care facilities, not just in Saskatoon Health Region, but also across Canada. So some considerations included sort of looking at are carbon monoxide detectors themselves protective for these residents that have physiological vulnerabilities. So because of the care home residents that a lot of them have cardiovascular disease, respiratory disease, or are just sort of frail elderly, they are affected at these low-level exposures. So that's one of the important things that we needed to understand. is that the framework that has to be used and the strategy would need to take into account that we're not necessarily looking at those higher levels that cause poisonings and acute poisonings and health effects. We're looking at the low levels of exposure, around 10 to 30 parts per million, over a longer period of time, say 24 hours or even weeks or months. And that would actually cause health effects in these individuals. Not only that, but we wanted to understand that care home residents differ from sort of the normal healthy population in the sense that they spend a substantial amount of time indoors in these long-term care facilities. They do have outdoor activities, but a lot of them may not be able to actually go outdoors due to their conditions, or that they spend most of the time indoors anyhow. The third thing about this population, in terms of contextualizing the strategy, would be that these individuals have limited ability to respond to any exposures. So they may have they may be immobile, or that they can't express that there is a certain issue or symptom that they feel and communicate that to care staff. So that's one of the third issues about that was found there. Another thing was that what would be important elements to a policy or strategy? And that was actually discussed, and it was concluded that in some of the discussions that day or during that workshop is that there would be components of educating staff, installing detectors, responding appropriately based on the levels you're seeing, and monitoring, right, on a daily basis. And that's what was sort of discussed at that meeting. In 2015, we actually examined in detail Saskatoon Health Region's existing policy. So they implemented this policy started to do it in 2010, shortly after the incident, but refined it over the years. And we wanted to understand sort of explicitly and articulate in an articulate way, describe their policy so that others can understand what they did and how they did it. So we did that examination through site visits and talking to the administrators, as well as different individuals that worked in that environment and were involved in leading the policy, implementing the policy, and directly sort of tasked with the day-to-day monitoring in these facilities. And after that, we actually did a formal evaluation. It was an evaluation of 10 long-term care facilities. We looked at not only the training that was provided, but also the data that they collected over time, and tried to see if they actually were able to capture those exceedances that would not have been captured, and if not, then health outcomes may have arisen if they weren't prevented or sort of mitigative actions weren't done or a proper response wasn't given. So that's what we looked at in 2015. And in 2016, we actually took all that information and to create this carbon monoxide monitoring and response framework, which had those three components of education, monitoring, and response, or prevention and mitigation. So in the end, we actually came up with sort of these 3 points that we found that through this process, we could identify that, first of all, carbon monoxide is a potential threat and under-recognized threat in long-term care facilities because of the target population that we're looking into and their physiological vulnerabilities, but also for staff as well for an occupational health perspective. And it can also, that this carbon monoxide monitoring response framework can be adapted locally. So in different contexts, we looked at different facilities, both in rural and urban settings, as well as in different capacities in terms of the resources, the public health resources that they have at these facilities. So larger size facilities, like over 200 beds, for example, to smaller size facilities, under 40 or 50 beds. So those are the types of, that's how we sort of understood what are the challenges and also facilitators for doing this at different types of facilities, and understood more about the context that these facilities could have and the differences. And then we tried to understand how in Saskatoon Health Region those learnings and also their process could be done in other health authorities across Canada. So what are the roles and responsibilities for individuals involved in this policy? And then we could try to understand that what are the parallel partners in other health authorities that could take on this type of work and implement a similar type of framework that supports all of the discussions that were had in 2013 that would produce an effective management strategy in long-term care facilities. So that's the adapt stage.
Great, Daniel. Thanks for describing that. And you know, from the point of view that we tend to take on the adapt phase, this is a really illustrative example because adapt phase, probably more than some of the ones that come before it, really involves that stakeholder consultation and discussion, really understanding what the issues were, some of that checking in about the different roles and capacities that are available. So all of that tends to come out when we do the adapt stage, really trying to take some general kinds of interventions or directions and put them into a setting and ensure that they work. So one of the tools that we at NCCMT tend to suggest for the adapt stage, and this is a tool that applies across the board, so intended to be a generic tool. It's called the Applicability and Transferability of Evidence tool. And so this tool is really a set of questions that you could ask in a consultation or ask with stakeholders or participants to get different perspectives on whether an intervention that maybe worked somewhere else or seems like it might work in this context, will it work here? And so it just prompts you to consider all angles of that input into decision making and see those kinds of adaptations or adjustments that might be made so that, as Daniel was saying, something that might work in a larger context, a larger facility, just might not work in a smaller facility, and that might not be equally understood by everyone around the table. And so to have those different perspectives come into play so that all of those needs for adjustments and changes to fit the capacity are really looked after. So that's the adapt stage. And then from there, moving around the wheel, we go to the implement stage. And of course, this is the doing part, but there's nothing like a good plan to help with the implement stage. And we're at this point deciding how to implement the change in practice or policy. When we think about a policy, probably many of us have been in the situation where a policy comes out, that is something that's written down on paper, but the rollout isn't really there in terms of providing the training or maybe even for people to know that that's the policy now. When is it going to come into effect? What's the phase in? So yes, there's the question of writing down the policy and maybe passing it at a board level or whatever the process might be. But implementation is much more than that. Implementation also involves training people, and Daniel talked about that as being an important part of any kind of process that would respond to carbon monoxide. We also think about what roles will be needed to implement this change. Another thing that we think about at the implementation phase is what's going to have to stop as we implement this new change. Now, in this particular situation, it seems like there wasn't necessarily a lot in place, and so most of the implementation was adding something new or new things. But in some cases, implementation involves first phasing out a particular way of doing something and phasing in another way of doing it, or phasing out one way that people used to spend their time and phasing in another thing that people are being asked to do in their public health practice. So the implementation stage is the doing part, but it's also the planning part and being sure that all the pieces were in place. So again, I'll turn over to Daniel to talk about how that, that process happened in this particular case.
Sure. In this case, when we looked at implementation, we need to understand, first of all, did the sort of previous policy or previous practice, is there any evidence of its effectiveness, and also what is needed to be considered if you wanted to contextualize it to another setting? So that's what we were trying to understand. And through the evaluation of Saskatoon Health Region's policy, we're able to answer a couple of those questions. First of all is that we were able to sort of verify that they were able to capture those exceedances. So over 100 exceedances were identified in a period of about 1.5 years at 10 long-term care facilities. And, the ranges were adequate in terms of, or the ranges that they captured were adequate in terms of the levels of carbon monoxide. So they range from really low levels, like 10 parts per million, which is what we're looking for, that are still relevant to these residents at these facilities, but also to higher levels, like over 150. So these would actually set off alarms. And the different types of responses that were exercised at these facilities during that time, and also some of which were presented in media over the years. So these incidences and the sort of validation of the process and the policy that they went through and its effectiveness were seen both not only through our evaluation, but also of a sort of cursory look at what's in the media. So it was quite great to see that this was working over in Saskatoon Health Region. And in BC, we wanted to see if it would work in a similar but different province and also health authority. So in Interior Health Authority in BC, we wanted to pilot a similar framework. And that's what we did. And first, what we did was approached the health protection or the health department in Interior Health. So that is sort of led to discussions on what's needed and the logistics behind implementing this. But also educating or sort of a discussion about, why this is the rationale for doing this, and also the people that need to be involved. And that's through the understanding of the roles and responsibilities in Saskatoon Health Region and the individuals there, and how it could look in Interior Health. So that was the initial discussion. And after we decided that, yes, we want to try to do this here and also set it up so that we can evaluate it after, there was an internal working group that was created, and that was spearheaded through the health department by an environmental health officer, and he was able to coordinate with all these other departments that, at the NCCEH I would not have known about. So he was able to do that internally, and that's sort of the capacity building aspect that we like to see in terms of they're able to take on the information we're providing them and use it in their local context and their local organizational structure in their health authority to try to figure out, the types of people that are needed to implement this innovative framework in their long-term care facilities. So 6 long-term care facilities were selected with the varying sort of sizes as well as the rural-urban mix that we wanted to see. And then we did training to disseminate that information, not only first at the sort of a higher level to the managers of these facilities and other stakeholders that are involved in the day-to-day operations, getting the okay from them, and then also training through webinars and presentations to staff that would be involved in implementing the pilot policy, as well as other staff who would need to know about carbon monoxide's health effects, the sources, and sort of just the response in general in the facility, because some of these responses require a sort of site-wide response if it's really bad in terms of the exposures that you're seeing or potentially seeing. But most of the time it's not the case, although we like to prime individuals to be able to respond to the varying levels that you may see, whether it be low or very high, and how widespread those are. So those are the types of methods we use to help disseminate that information. to allow Interior Health to implement this pilot project. On the next slide, this is a guide that we actually created based on the learnings from going through the process with Interior Health implementing the pilot project, as well as the sort of dissection of the policy and examination of the policy in Saskatoon Health Region. And this guide is actually online. It's currently published on our website at NCCEH.ca. You can just search carbon monoxide on our website, and you'll find a page with all these resources related to this project. And this is one of them. It provides the rationale for implementing this if you wish to. Some of the background that goes into it that I sort of described in the initial incident in the beginning of this presentation, as well as an overview of the actual framework itself and the 3 components. We also outline steps that you can typically use, and all of this is just to guide the potential implementation in other jurisdictions across Canada. Of course, you would need to contextualize again to your own local context, but this is sort of a good framework to use that hopefully other jurisdictions can decide whether or not this is, first of all, an issue in their health authorities, and then if they want to, pilot using this guide. And in the next slide, I think we're going to go on to looking at the evaluation.
Yeah, perfect. Thanks, Daniel. And that is, in fact, the next step. So after the implementation step, and as you've heard from how Daniel was describing what happened in the implementation step, there's lots involved. In fact, they have a whole guide that can help with that, and the process of checking in with people to see how it's going. Pilot tests are often a feature of implementation, that you would do implementation on a smaller scale first, then maybe do some evaluation and make some changes, go around the wheel again to make some of those tweaks and before you get to full implementation. So once you've gone through some part of the implementation, then of course you want to evaluate. So in this step, we are assessing the effectiveness of the change in practice or policy. So did it work? For whom? How well did it work? Are there any changes that might have been needed? And sometimes we also ask about the effectiveness of the implementation. So not only did we get the outcomes that we were looking for, but we might also at this stage evaluate whether the implementation was done the way it was supposed to be or the way it was planned. So we might be evaluating things like, did the right people actually get trained? Was the training actually delivered? Do people report that they understand what their roles are? If implementation required new roles or new people to be hired or deployed in different ways, has that actually happened? So all of those things are the kinds of questions that we would look at and evaluate. So it's not only about those sort of longer-term outcome indicators, but also some of those shorter-term implementation indicators that might be of interest. So in the evaluate step, we are evaluating the effectiveness of the implementation efforts. And so, again, I'll turn over to Daniel just to describe how that played out in this example.
Yeah, so following sort of the best practice models in public health nowadays is sort of when you implement anything, the best practice is to actually evaluate it as well. So that's what we did in terms of looking at Interior Health's pilot and how it was done. So we used a similar evaluation framework as we did in Saskatoon Health Region so that we can kind of see the similarities and differences there. And what we were really trying to find out is whether or not first that the short-term outcomes were possible, because we're not looking at a large project or a long-term sort of period of time that this was implemented. It was only done for about 3 to 6 months in interior health. There's only really enough data to describe the short-term outcomes that are potentially possible in terms of its effects and implementing the process. So we're really looking at whether or not it was implemented as planned. So the 3 components I was talking about in terms of educating the staff about health effects, and the training that was involved, how effective was that, and the knowledge retention of the staff involved in the daily tasks, as well as monitoring, because that's a key component in terms of daily monitoring and installation of the detectors in the right areas, and also identifying the levels that were relevant to health. So anything above 10 parts per million, what was the response that was implemented, and was that the type of response we were expecting, and is it appropriate in terms of protecting the potential health outcomes that may result if those weren't addressed. So we looked into that through interviews of the facilities plant services staff, as well as supervisors and also some regional departments. We also looked at the facilitators and barriers. So what worked in terms of the training? Was the training only necessary at this webinar level, or was it an on-site training needed or better? Maybe one of those aren't necessary, and what types of information? Was there extra information that could have been left out in certain types of training for certain staff, and that was sort of relevant at the frontline level, but not as relevant at the supervisor management level, and vice versa. So understanding the differences in training needs there was one of the things we tried to understand. And then also what could be improved in terms of helping the individuals conduct the daily monitoring, for example, or even reporting of the results on a monthly basis, because that was one of the requirements as well. And the most importantly is, did the intervention have its intended outcome of capturing the elevated indoor CO levels? Yes, it did. So we were able to verify that over 50 exceedances actually were exceedances greater than 10 parts per million were recorded, and then response actions that were appropriate were implemented by staff at the facilities based on the procedures that were implemented and the staff were trained on. So that was good to see that it was successful in terms of both the training as well as the monitoring and response. And finally, that the experiences here, as well as the past experiences and knowledge gained from the Saskatoon Health Region policy and their evaluations, so both of these evaluations and policies sort of rolled up into one. We created a guide in the next slide, which is available online as well on the same site, NCCEH.ca, just search carbon monoxide. And this really provides a framework for doing the evaluation that we did. It's brief, not that brief, but it's sort of in a packaged format where hopefully individuals have enough information that you don't need to be a credentialed evaluator to actually evaluate the pilot that you've implemented. So this goes through the evaluations design, the approach that we took or that we recommend for this type of framework, and also the key questions and indicators and sample resources, and also external resources that you can refer to if you wanted to do a more in-depth evaluation or a more formal evaluation. But this is a good start in terms of any individual who might want to evaluate the carbon monoxide monitoring response framework in their long-term care facilities, because you don't need necessarily a formal evaluator to do this. And that's what we're trying to encourage, is that if you can't hire or have an external evaluator available, you can still have people in your health authority do this. And that's sort of all I have to say about that. Susan?
Yeah, thanks. Thanks, Daniel. That's great. Interesting step that you took there. And so certainly for people who are interested in that, in implementing something related to CO monitoring, the resource that Daniel just talked about would be a great source. And another tool that I can suggest related to evaluate, this is a more generic tool, so not related to CO exposures or monitoring, is called Improving Future Decisions, Optimizing the Decision Process from Lessons Learned. This is a different kind of evaluation tool. It's really a tool that helps people to evaluate the use of evidence in making decisions. So for organizations that are moving toward an evidence-informed decision-making process, this tool is a reflective practice tool. So it guides you through some questions to ask about how well did you find and use the best available evidence? What was the implementation process like? How able were you to make changes, adapt, take different factors into account, understand the context? All of those kinds of things that go into good use and application of evidence are summarized in this tool. So a really different take on evaluation, but one that might be of interest as well. So as we've seen, these 7 steps in the process of evidence-informed public health really showed up in the long-term care facility example that Daniel talked about. Now, this wasn't a model that they started with explicitly, but just by doing a good systematic process, all of these aspects showed up in one way or another in the process that they used. And as we've seen, particularly in those steps of adapting to local context, implementing, and evaluating, there really is quite a bit to know in terms of what might be needed at each step. If you're interested in taking an evidence-informed decision-making approach in general, there is a checklist, and the source can be found at NCCMT.ca that just prompts through each of those 7 steps in the model that I was talking about. So that might be of interest to you as well. And one other tool that I'll talk about before we get into some questions, but you can start thinking about questions now, and if you do have questions or comments, you can enter them in the chat box, so you can sort of get started with that. But as you're preparing your questions, I'll just mention the NCCMT registry of methods and tools. The methods and tools that I talked about today that are more generic and not specific to environmental health or really to any topic, but more about the process of evidence-informed public health. The ones that I talked about today, plus lots of others, are listed in this registry that you can search. So if you're looking for a method to critically appraise the quality of evidence, you'll find that there. If you're looking for tools that will help with the implementation process, you'll find tools there. Resources that will help with evaluation, you'll find those there. So the registry front page looks like this, just so that you know you're in the right place. These are methods and tools related to knowledge translation, so finding and using good quality evidence in making decisions. So now we have some time for comments and questions, so I will encourage you to use the chat box to post your comments and questions. Lots of interesting aspects to this long-term care facility example and the monitoring and responses to carbon monoxide. So please go ahead and post questions or comments, and we'll be happy to address those as we go. And I'm going to turn back now to Emily Clark to moderate our discussion session at this point. So Emily, back to you.
Thank you so much, Susan and Daniel. What a great presentation, going through the entire process involved in getting this pilot and this program done. Daniel, I heard a beep. Are you still on the line?
Yep.
Okay, perfect. Just making sure. So for anybody who does have a comment or a question, make sure that you send it ideally to all participants and hit send. You could also send privately to host if you're a little bit shy. That's not a problem. While we're waiting for questions to come in, Daniel, I'm wondering, while you were implementing this program, did you encounter any barriers? Was there any resistance while you were trying to implement this?
Well, I'm not sure if it's a barrier, but sort of a challenge is actually explaining the rationale. I mean, it's not that it's difficult to understand after the fact, but it's that carbon monoxide, everybody thinks it's this thing where it's carbon monoxide poisoning, and we're really looking at health effects for these physiological vulnerable populations, right? So it's different, and that's the mindset I think was a little bit more difficult in terms of having the proper explanation and also addressing the questions that come up, because people often will be like, okay, why don't you just install detectors? You know, why do we need to monitor them as well? And it's really the case that we're looking at these low-level exposures where these detectors aren't actually effective to addressing those at all. So, and at least the current ones that are available. So, and also making the process I guess that you can implement this in different types of facilities that are either less resourced or more resourced. So we need to understand that as well and make it work for them. So that was one of the, I guess, challenges to, you know, really getting the buy-in initially and properly explaining, you know, why this is actually an under-recognized threat in long-term care facilities that people don't necessarily think about, but it's probably everywhere, you know, so in different types of facilities, yeah.
And I mean, on that note, this probably is potentially a Canada-wide issue, and it sounds like a very logical problem to address. Do you think there is any potential for policy change, either at a provincial or a federal level on this?
Well, I mean, at this point, federally, we're supported through Health Canada to do this work, so it is in line with helping to provide an approach to meet the Health Canada indoor air maximum exposure limits for carbon monoxide. So that's one of the things that we would try to use to promote this, and the implementation of it across Canada is that without a certain method to do that, you cannot ensure that residents aren't being exposed to levels that may be impacting their health. So that's one of the ways we were looking at that.
Great. All right. So I haven't seen any other questions come through. I will just advance a little bit here. Your feedback, so thanks again to everybody who has joined us today. Your feedback is very important to us. There is a very short survey available. It's really only a few questions available at the link that is now posted in the chat window now. So please take a few minutes and fill out that survey. I believe that survey will also pop open once you close the window. So we are looking for feedback both to improve this webinar series as well as other webinar series run by NCCMT and NCCEH. So we really do appreciate any feedback that you have. We did just get another question in. So the comment and question are, I gathered that a lot is being done to protect the health of our residents in the long-term care facilities. What is being done to protect the health of folks, especially children, in residential homes?
Yeah, I can answer a little bit of that. I mean, outside of long-term care facilities, you know, they're not regulated. I mean, private residences aren't regulated in any way, so it's a little more difficult to, first of all, understand how we could potentially manage that, and also the health effects may be different in children versus residents in long-term care, so that would require looking at, again, the context and the environment that children are in. But in homes, that is definitely something we're considering in terms of individuals with similar conditions that don't live in long-term care facilities. So people with cardiovascular diseases, like maybe respiratory ailments like COPD, that have issues with sort of the exchange of carbon monoxide from their bodies and also the accumulation of carbon monoxide in their bodies. So those are considerations for potentially seeing that there's other susceptible individuals that currently have no sort of systematic way of protecting them. But right now, in homes, you can get residential carbon monoxide detectors that are the ones that we use in these facilities. And although they don't sort of notify at these lower levels, some of them have displays where you can see those levels. And if you press the sort of peak level reading button every 24 hours, you can actually see if there are any readings. And that's sort of one way you can try to, understand if there are potential exposures in the home. But that's a little more difficult to address because of the way they're sort of private homes, and public health or other health departments aren't necessarily involved in looking at those at this time. So.
Great, thanks, Daniel. I will also introduce the next webinar in this webinar series. We'll be looking at methods and tools instead of for an environmental health issue for integrating health equity into public health program planning and implementation. This webinar will be done jointly between the NCCMT and the National Collaborating Center for Determinants of Health. We will also have a couple of panelists join from a health unit in Niagara region to discuss how they have implemented this. So we should have a very great discussion on this one. This will be held on Wednesday, June the 28th at the same time as this webinar. The link to register has been posted in the chat section and is also in our monthly roundup newsletter. So we'd be very happy to see you again there. I haven't seen any other questions. I will close here. For more information on either the work of the NCCMT or NCCEH, the websites are listed on the screen and in your chat box right now. I will pass it back to Susan and Daniel in case you have any more questions before we wrap up. But I do want to thank you for an excellent presentation, and thanks to everybody who stuck with us this afternoon.
Well, thanks, Emily. It's Susan here, and just want to say thank you for Daniel for sharing this good and interesting example. Lots of nuances there, and certainly points to the value of bringing evidence to bear when a situation arises, and you sort of realize that perhaps something can be done or should be done, but then figuring out what it is and actually making it happen is really quite a complex process in itself. So thank you very much for that presentation, and thanks to everyone who was listening.